What is DIC? Or disseminated intravascular coagulation? It is an inappropriate intravascular deposition of fibrin with consumption of coagulation factors and platelets as a consequence of many disorders that release procoagulant materials into the circulation or cause endothelial damage or platelet aggregation causing excessive bleeding. Causes and risk factors. After injury, proteins in the blood form a blood clot that travels to the site of injury to help stoppage of bleeding. Clot happens due to sticking between fibrin mesh and platelet plug. If these proteins become abnormally active throughout the body, development of DIC occurs. This happens in cases of inflammation, in response to infection, injury, or illness. Infection, sepsis, a body-wide response to infection that causes inflammation. Infection may be caused by parasites, bacteria, fungi, or viruses. Cancers, including cancer affecting pancreas, stomach, colon, or blood. Severe tissue damage following surgery, trauma, or after severe burns. Recent surgery or anesthesia. Blood vessel abnormalities including aortic aneurysm or large hemangiomas. Obstetric complications like amniotic fluid embolism, premature separation of placenta, or septic abortion. Liver diseases, whether liver failure or liver cirrhosis. Lifestyle habits, toxic drug reactions, or frostbite. Severe immune reactions, incompatible blood transfusion, rejection of organ transplant and toxins. Shock, any condition that causes ischemic tissue injury and exposure or release of tissue factor. Massive blood loss. Hypothermia, which is extremely low body temperature. Enzymes of certain snake venoms that enters the circulation and activate clotting factors. Pathophysiology of DIC. Uncontrolled and excessive production of thrombin with systemic intravascular fibrin deposition. Blood exposed to procoagulants mediated by extrinsic pathway. Tissue factor and activated factor 7 leads to formation of platelet aggregation. This happens normally after injury and it is controlled by antithrombin and tissue factor pathway inhibitor. But in DIC, control mechanisms are overwhelmed. Leading to consumption of platelets, fibrinogen, prothrombin, and factors 5 and 8. Tissue ischemia, as clot may block blood supply to tissue. Bleeding due to excessive consumption of clotting factors. Massive activation of clotting cascade by release of tissue thromboplastin into circulation, extensive injury to vascular endothelium, expression of tissue factors by monocytes. This leads to loss of control, fibrin degradation byproducts in massive amounts, has an anticoagulant action and inhibits clotting, interferes with platelet aggregation. Plasmin lyses other clotting factors and fibrinogen, worsens consumption, coagulopathy.
Symptoms and signs of DIC. Blood clots form throughout the body. Small blood vessel can cause. This picture indicates a clot that prevents the blood supply to the organ. So, if the blood clots form in the vessel of the lung, there will be chest pain and shortness of breath. As this patient. If the blood clot form in the deep veins of the leg, there will be pain, redness, hotness, and swelling in the lower leg. If the blood clots form in the vessel in your brain, headache, paralysis, dizziness, and symptoms indicate stroke. The amount of the damage depends on which side in the brain that blood doesn't reach to it. If the blood clots lodge in your heart, lungs, or kidneys, heart attack, lung and kidney problems, and these organs may begin to fail. In the first picture, that indicate a clot in the renal vein, which prevents the blood supply to the kidney. The increasing clotting activity uses up the platelet and clotting factor in the blood. As a result, serious bleeding can occur. DIC can cause internal and external bleeding. Internal bleeding can't be seen. It happens in the body's organ, which can be life-threatening. There is blood in urine and stool, pain, headache, and tenderness. The other type, external bleeding, which can be seen, and there is a pallor and sweating nausea, redness, or swelling from the cuts and scratches of the skin that will cause purpura and petechia.
Diagnosis of disseminated intravascular coagulation. Let's go to discuss this important diagnosis. First point, history of clinical diagnosis. Need to look at entire clinical picture to lead to a diagnosis of DIC. Clinical diagnosis is important because some diseases as liver disease can essentially have the same laboratory finding. Second point, lab finding. We look at labs that common associated with DIC. Then, scoring system. We take a look at a scoring system that can help us in our diagnosis. We can show important clinical picture which lead to diagnosis of DIC. Pallor, ecchymosis, petechia, chest pain, dyspnea. Lab markers consistent with DIC include platelet test show low platelet count. Let's take a look at thrombocytopenia. Which develops in DIC because the activation of clotting and the consumption of platelets by clot formation. Which considered as sensitive test but not specific. Other important lab markers show prolongation of partial thromboplastin time, prolongation of prothrombin time. PTT measure intrinsic pathway and PT measure extrinsic pathway. In about 50 to 60% of patients have DIC have prolonged PT and prolonged PTT, which reflect low circulation coagulation factor. Actually, we use PT and PTT to monitor DIC patient because they measure the pathway that involve the factors that are consumed in DIC. In labs, we can exist high fibrin degradation products. Fibrinogen degradation products are a result of clotting system activation and causing the cleavage of fibrinogen to fibrin. We measure fibrin degradation products in DIC if the body is activating the clotting system at a very rapid rate of fibrinogen. which converted to fibrin very quickly, producing a lot of fibrin degradation products. We must take care of fibrin degradation products are hepatically and renal metabolized. So, any hepatic or renal dysfunction may lead to vastly elevated level of fibrin degradation products. We should also put into account high D-dimer. D-dimer, one of the protein fragments produced when a blood clot gets dissolved in the body. It's normally undetectable or detectable at a very low level, unless the body is forming and breaking down blood clots. Then its level in the blood can significantly rise, which can be detected in the blood. Important note: fibrin degradation products, including D-dimers, shouldn't be considered as stand-alone tests in DIC. One of the important tests useful in this case is fibrinogen. Low fibrinogen is classically used to diagnose and monitor DIC. However, must realize fibrinogen in most cases not be very helpful. And the reason why is fibrinogen has a very low sensitivity for diagnosis of DIC of about 28%. We can take a look at histiocytes in blood film. Fragmented red blood cells, although reported in patients with DIC, rarely more than 10% of red blood cells. However, in some cases of chronic DIC with elevated D-dimers but normal coagulation screening assay results, the presence of fragmented red blood cells can provide confirmatory evidence. The finding of fragments is neither sensitive nor specific to DIC. When they seen in increased numbers, other potential diagnoses such as thrombotic thrombocytopenic purpura and other causes of thrombotic microangiopathy should be considered. We can see histiocytes are typically irregular shape and have 2 points.
Treatment of disseminated intravascular coagulation. Treatment for DIC depends on its severity and symptoms. The main goals of treatment for DIC are to control clotting and bleeding, and to treat the underlying causes. Cause: treatment of the cause if possible. Antibiotics for infection. Bleeding. Can be treated by replacement therapy. Is indicated in patients with dangerous or extensive bleeding. Supportive therapy such as fresh frozen plasma, platelet transfusion. red cell transfusion may be used in the cause of severe hemolytic anemia. Thrombosis treated by the use of heparin, antiplatelet drugs to inhibit the coagulation process is considered in those with thrombotic problems such as skin ischemia. Antifibrolytic epsilons and aminocarbonic acid are effective in treating bleeding, although the use of these drugs in patients with the organ failure or non-symptomatic type of DIC generally not recommended. Its use is controversial. It may accelerate microvascular clotting.
Reticulocytes preparation. Whole blood is mixed with supervital dye, such as neomethylene blue. Blood smear are prepared and incubated at room temperature for 10 to 20 minutes. The dye causes clumping and staining of residual nucleic acid presented in immature cells. The stained cells are counted as a percentage of total red blood cells. This blood film shows reticulocytes which normally can give less than 3% of total red blood cells. It can be seen as large cells with bluish cytoplasm appearance due to ribosomal RNA. Principle of complete blood count machine. The traditional method for counting cells is electrical impedance, also known as Coulter principle. Whole blood is passed between two electrodes through an aperture so narrow that only one cell can pass through at a time. As we see in this picture. Principle of stegocoagulation analyzer. Two principles are used for the mechanical clot detection in the routinely used coagulation instruments. When the oscillation decreases to a predefined rate, the timer stops, indicating the clotting time of the plasma.
Principle of seismic hematology analyzer. Blood is sampled and diluted and moves through a tube thin enough that cells pass by one at a time. Characteristics about the cell are measured using lasers, fluorescence flow cytometry, or electrical impedance. Principle of ESR. Erythrocyte sedimentation rate. When saturated blood in a vertically positioned Western green pipette is lifted undisturbed, red cell aggregate stacked together to form rouleau and sediment through the plasma. The ESR is the rate at which this sedimentation occurs in 1 hour as indicated by the length of the column of clear plasma above the red cell, measured in millimeter. Fibrinogen, immunoglobulin, and C-reactive protein increase red cell aggregation. Principle of blood film. We prepare a peripheral blood smear with Leishman stain techniques, which is done by placing a drop of blood on end of a slide and using a spreader slide to disperse the blood over the slide's length. The aim is to get a region called monolayer, where the cells are spaced far enough apart to be counted and differentiated. The first slide is the correct slide. Steps of quality control of automated devices. The known sample, which is prepared from the company, is run in the device before we start the work. We ensure that the value of this sample is correct, within reference range. If the value isn't within reference range, the device is not ready to give a true result of specimens.